helping to facilitate the question and answer session. You can put your questions in the chat if you have access to the chat. If you're on the computer, you can also send me an email or text me. Sometimes people text me with questions, and then we'll go to 1 o'clock, and then from 1 to 1:15 we'll have a question and answer. Thank you, Erica Mora, for in advance for your help and during the presentation. Also, what you and Dr. Zhao have been doing in setting up all the grand rounds. And Dr. Jain has the code to text up right now, but you usually put that periodically in the chat for people as well. So I'm going to introduce Dr. Jain first by reading her bio, and then just saying a little bit about her and my own experience. So Dr. Jain is an assistant professor of psychiatry and associate program director for the Geriatric Psychiatry Fellowship at UConn Health. She is also the director of telehealth services for the Department of Psychiatry at UConn Health, which is really the capacity she's here talking with us in today. She received her undergraduate in medical education at LLRM Medical College in Meerut, India. She received general psychiatry training at University of Mississippi Medical Center and the West Virginia University Charleston Area Medical Center. She completed a geriatric psychiatry fellowship at the University of Pittsburgh Medical Center, UPMC. Prior to her arrival at UConn, she served as a staff psychiatrist at Cornell Scott Hill Health Center and was an assistant clinical professor at Yale. As part of the UConn faculty, Dr. Jain has assumed a key clinical and educational role, expanding outpatient clinical services for older adults, teaching medical students and residents, and helping develop the Geriatric Psychiatry Fellowship. She has led efforts to establish and expand telehealth services at UConn Health over the past 2 years. And Rob, I'm getting a little feedback. I don't know, Neha, do you hear the feedback when I talk?
It's very mild. I wonder if it would help if I muted myself.
Well, I don't get it when you talk, so that's the important thing. And just on a personal note, so and this is such a timely. I mean, couldn't be more timely to be hearing this presentation, Trial by Fire, Telepsychiatry during and beyond the pandemic. And actually with Dr. Jain, it's also before the pandemic, because she was already doing a lot of work on telepsychiatry before the pandemic hit. We've clearly are in a very different world than if we were talking a year and a half ago. We would be like, oh, that's kind of interesting. Maybe we'll get there someday. And maybe it's more convenient and there's some advantages, but I don't know if I really want to do it. Now, I mean, I can't remember our numbers. Maybe you'll talk about your numbers, but we went from something like 500 telepsych visits, or maybe even fewer, to like tens of thousands, if not hundreds of thousands of telepsych visits just in last year. So we're in a very different world, and very lucky to have Dr. Jain. She was one of the first people that I connected with at the beginning of the pandemic to learn about telepsychiatry. So very excited to have her here. And with that, I will turn the floor over to you.
Thank you so much, John, for that very kind introduction. I am honored and excited to be here today, and we will be talking about telepsychiatry, our experience both during and now hopefully beyond the pandemic. So I'll start with the CME disclosures. So this live activity is designated for 1.25 AMA credits. I believe the first slide told you how to access those credits, and we'll have that slide at the end as well. I do not have any financial conflicts of interest, and there is no commercial support for this activity. If you have questions, I welcome a lively discussion at the end. So feel free to put them in the chat, or you can raise your hand at the end of the presentation, and Rob will unmute you, and we will go over that. But so what the topics that we will cover today, I will start by telling our story, mostly because I love to tell our story, and I think it's very interesting. We will cover telehealth policies. We will cover lessons that we learned over this past year and some best practices that we established. We'll also talk about challenges that we are facing now and that are sure to come up in the future, a little bit about future directions, and then we'll have some Q&A at the end. So before I do that, let's start with some definitions. So when we think of telemedicine or telepsych, I typically use the term telepsych because I think that includes both telepsychiatry and telepsychology. But we think of, some sort of live back and forth through a video between a patient and a clinician. That's not necessarily all that telepsych is. Telepsych also includes asynchronous communications. So something like an e-visit where a patient sends you a secure message and you respond back would also be covered under this. Some sort of store and forward where you record a video and then forward it to a consultant would also be considered telepsych. Any kind of remote monitoring would be considered telepsych, and then e-consults, case-based teleconferencing, where I want to consult a specialist and I will send them all the information about a particular case, and then we will have a conference, is also considered telepsych. Telehealth is a slightly wider umbrella and actually includes educational activities like these grand rounds, as well as public health activities such as conferences and public educational efforts. And then the biggest umbrella term is digital health, which includes health information technology, wearable devices such as, all the way from Fitbits and smartphones to, CPAP machines and EKG devices that send the information directly to your doctor, as well as personalized medicine, using this information that we are collecting to come up with a personalized plan for the patient. And we are starting to do some of that. And I can't tell you, this is probably the most exciting part of telepsychiatry for me. But for the purposes of grand rounds today, we'll mostly be focusing on telepsych itself, providing direct clinical care in some way or form through telemedicine. So I'd like to tell you a little bit about our story, which I'm sure is somewhat similar to your story at the IOL in Hartford Hospital. In the beginning of March last year, we were almost 100% in person. Like John was saying, I had been interested in telepsychiatry for a long time, and I had actually started a pilot project using telepsychiatry where I was seeing some of our existing patients who had either moved away and couldn't make the drive, or their work hours didn't allow them to come see us to provide clinical care. And now I laugh, but I can tell you I had a total of 3 patients prior to March 1 of 2020 who I was seeing regularly using WebEx. On March 8th, we had our first confirmed case of COVID-19 in Connecticut. On March 10th, the governor declared a public health emergency. On March 11th, we had our first Doxy.me account. On March 16th, I believe that was a Monday, as schools closed, we conducted our first virtual visit. On March 17th, so the day after, we had 21 clinicians using Doxy.me. Ryan Haidt was suspended. On March 18th, UConn approved work from home. On March 20th, the governor issued stay home, stay safe orders. By March 24th, all of psychiatry had transitioned to telepsych. And so on March 30th, within a span of 4 weeks, we went from 100% in person to almost 100% telehealth. And so, the way I think most of us think of it, we built this plane while flying, which was very interesting when it was happening. But the fact that we all survived, I think, says something. And I'll show you some numbers, which again still fascinate me. So this is our in-person outpatient psychiatry visits at UConn Health. And as you expect, this huge drop from over 2,500, 3,000 it's down to 0 during that period of March and April. This was offset a little bit by telephone visits. So that orange line is telephone visits, and you can see that sort of peaked in April and then stabilized after that. Offset a lot more by telehealth visits. And so here by telehealth, I mean just video. So our video visit volume went up and stayed up. And as a result of that, this teal line is actually our total outpatient psychiatry visits. And as you can see, there was not a huge drop from our high volume, even during the peak of the pandemic. And we recovered very quickly. Now, to put that in contrast, I have some national data. So to the left is the graph of national outpatient visits, though this is not psychiatry specific, this is general outpatient visits. The blue line is outpatient visits across the country, and the orange line is the tri-state area. So New York, New Jersey, Connecticut, who you know were hit harder in the beginning of the pandemic. And as you can see, outpatient providers saw their visit levels drop by almost 70% in this area. In contrast to that, at UConn Psychiatry, our levels dropped by 12% and recovered fairly quickly. So in terms of the ability to continue providing mental health care at a time which was extremely anxiety-provoking across the country, this was very, very important. And because I like numbers, we've continued to collect numbers. And this is interesting. Now, this is data from January of last year all the way to March of 2021. And as you can see, our telehealth visits have continued to climb, as have our total outpatient visits. And what's interesting is that those two lines are pretty parallel to each other. So the increase in outpatient visits is mostly being driven by telehealth. And I think this is something we need to keep in mind when we think about access to care and maintaining access to care into the future. So latest results from 2021. So I just put together the numbers from January to May of this year. You know, we have on an average about 3,500 outpatient psychiatry visits. And even now, with the pandemic being quote unquote over, 72% of these are video visits, 10% of these are phone visits, and about 20% are in-person visits. And I will tell you, the past month, when I talk to patients over Zoom, I always say, okay, we're seeing patients in person. Would you like to continue using Zoom, or would you like to come in person? And the vast, vast, vast majority of my patients want to stick with Zoom because it's more convenient for them. And again, this is not just us, this is nationwide. So we do have numbers now from 2020, study being done. And this is actually, I believe, a CDC report that said telehealth accounted for 30% of total health center visits during the pandemic period. This is about 29 billion in revenue in this country. And the doximity projections are that this is going to grow to 106 billion over the next 2 years. So we know that the demand is there and we know the supply is there. But numbers alone obviously don't define success, right? So number of visits is one thing. Financial outcomes is one thing. But we also want to look at patient satisfaction and patient experience. We want to look at provider satisfaction and provider experience. We want to look at clinical outcomes. Does this actually work? And last but not the least, we want to make sure, is this equitable? Is this inclusive? Are we leaving people behind when we jump onto the digital bandwagon? And we're going to talk about some of these things. So what changed? I love using the phrase zombie apocalypse because I remember very clearly on March 1st, I went to the leadership and I said, we need to be ready. We need to transition to telepsychiatry. And they said, well, get everything ready, but we really don't foresee this happening unless there is a zombie apocalypse. And 2 days later, there was the zombie apocalypse. So a lot of things changed. Pre-COVID, telemedicine was there. Telemedicine had existed for a long time. But during COVID, all of a sudden, it became the safe option. And so that patient discomfort with tech was all of a sudden replaced by, oh, yes, I'm using Zoom or FaceTime or Skype to talk to my children and grandchildren and friends. I can use this to talk to my doctor. Before this, we used to prioritize seeing our patients in person. But during the pandemic, we all remember the priorities were actually, well, how do we preserve PPE? How do we protect our healthcare workers? The low reimbursements, the policies, and we'll talk about this in more detail, actually a lot of the barriers, a lot of the legal policy barriers to telemedicine were removed because of the pandemic. And that physician discomfort, this knee-jerk, oh my God, seeing my patients through video, was replaced, especially in our field, by this idea of the advantage of behavioral health, that we don't necessarily always need to lay hands on our patients, and that we can do a lot of clinical care over video. So let's talk a little bit about policy. I love this quote. There is a tremendous gap between public opinion and public policy, and I think that used to stand true for telehealth. So telemedicine policy in this country has always been, and still is, sort of a patchwork quilt, right? So every state has their own policy, and then the federal policies differ from the state policy, and you sort of patch everything together and hope you have something workable. So one way to think about telemedicine policy is in terms of what is the service being provided, where is the location, both of the patient and the provider, where the service is being provided, who is the provider who can use telemedicine, and how. Again, telemedicine includes a lot of different modalities. So how are they going to be providing the service? And I'll show you how all four of these slices of the pizza changed. So if you look at Medicare policy, right, prior to COVID, in terms of patient location, patient had to be in a rural or an underserved area. There was a limited facilities with limited services where you could actually provide telehealth. In terms of services that were covered, there was a very specific list of only 90 CPT codes where you could provide telehealth. There was, again, who could provide the service, very limited list, 9 type of health professionals that could provide telemedicine. And in terms of which modality you could use, live video was the only modality that you could use, which by itself precluded a large chunk of our population. Now, what happened with COVID, both at the federal and the state level? So if we look at the federal level in terms of Medicare issues, the geographical limitations were waived, the site limitations were waived, provider list was expanded. They added another 80 codes to the services that were eligible for telehealth. They waived visit limits. They added phone to the live video visits. They relaxed both supervision and licensing requirements. And they added other codes that were eligible for phone use. Likewise, state Medicaid, they included audio visits, and they're still including audio visits. They allowed patients to be at home, which was a big, big deal. They relaxed the consent requirements, so you didn't need to have the patient come in to provide a written consent. They expanded the type of services eligible. They allowed other providers to provide telehealth services, and they waived some licensing requirements. So as you can imagine, all of these policy changes, I would say perhaps played the biggest role in the success of telepsych that we saw last year. And what is the future going to look like? So this is a new slide because I have some information now. As you know, in the beginning of May, Telehealth Act was passed in Connecticut, and this act is effective until June of 2023. And this is just a very brief summary, but audio-only visits remain covered for in-network as well as CMAP, Connecticut Medical Assistance Program providers. So for your Medicaid and Husky providers and for in-network providers, you can still do a telephone visit and you'll be reimbursed. Ryan height is reinstated. So the federal pharmacy law that you have to see the patient at least once every 2 years if you're going to be prescribed controlled substances is back in action. This is important, though. A telehealth provider may still provide services, and I see a typo there, from any location. So you can still see patients from home if you want to do that. And because of that, you obviously cannot charge facility fees. So even if you are in your clinic and you're doing telehealth, you can no longer charge facility fees. And most important, there is reimbursement parity. So for plans that cover telehealth, they are required to reimburse them at the same rate as they would do an in-person visit. And this right now is going to remain active in Connecticut for another 2 years. And as I was searching through the Act, I found this really interesting legislative report of fiscal analysis. And what it said was that they expect that there is going to be additional patient care revenues generated because of this act, because one, patients who would otherwise forego in-person care are coming back and seeing their doctors because of telehealth. Two, more favorable telehealth reimbursement for providers than often exist in current contracts with payers. And three, patients are seeking out more healthcare because of the relative ease of telehealth for some. And I think all of these 3 points are very important. And so I believe this revenue, I think this is for UConn Health Center, not for psychiatry, but for UConn Health in general. They said that the revenues for financial year 2021 to date equal 1,200 times the total telehealth revenues for the calendar year 2019. So we know that in terms of number of visits, telehealth works. We know that in terms of financial outcomes, it works. Let's talk a little bit about practice of telepsych. So when we designed our program, our first question was, how is a virtual visit different from an in-person visit? And the answer was, everything is different. You know, how you prepare for the visit is different. The technology that you use is different. Your actual visit conduct is different. And your documentation and billing is different. So everything is different. But the key question for any clinical visit is, what information do I need to come up with a diagnosis and formulate a treatment plan? That question does not change. That question remains the same. And both an in-person visit and virtual visits can provide you with this information. So some of the hacks we came up with for a successful tele-visit, the first and most important one still is you need to know your platform. Doesn't matter what you're using, whether you're using Zoom or Doxy.me or Skype or FaceTime or Epic or Secure Video, you need to know the platform. You need to know what all the different buttons mean. And the best way to do that is to see one, do one, teach one. And so we did this during the launch of our program. I would individually run practice runs with every single clinician and then have them do that with their trainees so that we were all getting practice. Second, anytime you introduce something new, whether it's to a patient or to a clinician, expect some pushback, because as human beings, we do not like change. So expect people to be nervous and anxious and say, oh my God, I don't know how to do this. And if you're expecting that, it becomes easier for you to work with it. Prepare to troubleshoot with the patient. So problems come up, problems still come up. And I am always there. I can't think at that moment that, oh, as a doctor, it's not my job to help you with, your IT problem. It is my job to help you with the problem, and we troubleshoot all the time. And the most important thing when it comes to troubleshooting is to having a backup. So right now, at some point, we all transitioned from Doxy.me to Zoom. And Doxy, we have retained Doxy as our backup, which was a struggle, but we did, with the idea that we spend the first 5 minutes troubleshooting. And if for whatever reason Zoom is not working, either for me or for the patient, we switch to Doxy. If Doxy doesn't work, we switch to phone. But we don't waste time. We don't waste the whole visit trying to solve something that may not get solved. And then anticipate and explain future directions. So for example, now I have started asking patients, okay, what would you like to do for the next visit? Do you want to come in? Do you want to do Zoom? And when they say Zoom, I know that we're going to continue doing Zoom for another 3 months at least. And the more you expect this, you explain this to your staff and you explain this to your patients, the easier it gets because people know what they are getting into. This is a brief slide about the environment. I think at this time, all of you are very aware of this. So be aware of your lighting. You don't want to be sitting against the light. You always want light to be in the front or from the side. You want to be aware of your background and your surroundings, not just, pictures and things that are in your environment, but also background noise. What I didn't realize is how often our landscapers came to mow the lawn, and when they did, how long they spent there. So, I really had to figure that in when I started seeing patients from home. Another little hack that I learned is, if you that little frame where you see the patient, if you move that to right under the camera, that reduces that gaze angle. If I draw a straight line from my eyes to the camera and then from my eyes to where I'm seeing the patient, if that angle is less than 5 to 7 degrees, the patient can't perceive the difference. So I can minimize that zoom window and continue documentation while I'm talking to them. And to them, it does look like I am looking them in the eye, which I think is very important, part of a telepsych visit. Of course, I tell them that I'm typing, and I do use a silent keypad so that the typing is not distracting. The last point, in terms of connection, because a lot of people were very nervous about not being able to connect with the patient who's physically not present. But what we've realized is that we have all found new ways of establishing connection. So when a patient is at home and they have something interesting in the background, or they have a pet or a child that jumps into their lap, or, something happens in the background. So we weave those things in and we find new ways of connecting with our patients in this new environment. Right, some more best practices for clinical encounter. Maintain the same standards and protocol as an in-person encounter. Again, because the environment is different, I think, if anything, this becomes even more important. So common things that come up in terms of, there are other people in the room, or patient is driving, or patient is not dressed appropriately, or they are smoking or doing something else that may not be appropriate. So really reestablishing those boundaries, making sure that they understand. I did have a patient who was actually in the ED. So I called her and she turned the video on and she said, "I'm here in the emergency room. I had a tummy ache, but we can meet." And I said, "No, I really don't think we can. Let's reschedule. Let me know how, what happens, and we'll reschedule for when you have more privacy." So you have to maintain those protocols. What I do like about virtual encounters is that you can use observation. You're actually getting a mini window into the patient's environment. So they might be at home, they might be at work, they might be sitting in a car because they don't have a private space. What happens a lot with my patients, because they're geriatric, is I will ask them a question, they will say something, and then a spouse or a caregiver will yell from the background, "Oh, that's not true," or, "Tell her this." And I use that to say, "Oh, it sounds like, your wife is there. Oh yeah, she just walked in. Well, can I talk to her briefly?" And I use that moment to catch some collateral, which otherwise would be pretty hard to obtain in an in-person visit. So again, there are certain advantages to telehealth that we can use. We do now ask our patients to record vitals when they have access to a machine. And then questions about testing. So, tests like the MMSC and the MOCA, the Geriatric Depression Scale, AIMS, these can all be done virtually. And there is actually some data to support their validity. So it takes a little bit more time, but that doesn't mean you can't. So I have done all of these tests over video. We have recorded them, and they're just as accurate as when you do them in person. Same thing for labs and imaging. You can still do all of that, even if you're seeing the patient virtually. Psychotherapy visits. Now, psychotherapy visits have some unique challenges of their own. We had a very interesting story where one of our faculty members, who's a psychotherapist, reached out to me and said, "Neha, I think I'm doing everything right, but the patient keeps saying she can't see me, that she can only see the top half of my face, and I keep pushing the camera down, and I just don't know what's going on." So I did a test visit with her, and I said, "Well, I see you just fine. And so she's like, I don't know what's going on. She keeps saying she can't see me. This isn't enough. This isn't good enough. And I said, maybe the patient isn't speaking literally. Maybe they're speaking metaphorically. And so then they had a conversation with the patient about that, about how hard it was for this patient to not be in the same room with the therapist. And they worked their way through that. Likewise, we've all had the opposite experience of being providers who can't see the patient because patient is on their phone and they stick the phone to the ear because they think they're on a phone call. So, you spend a few minutes doing an ear exam and then you say, well, I need you to bring your phone to the front of your face. So we do this all the time. Another issue is with clinician fatigue. I certainly heard a lot about this in the beginning. It seems to have tapered down a bit, but I found this lovely quote. I think this was an article in the New York Times, maybe, Dr. Cynthia Chalker, who's a psychotherapist in New York, saying, with video, I find that I need to sit still and look, and the drama of faces is much more intense because I can see their faces close up. There is an intensity. I can see the tears. I can hear the cracks in the voices. And I think we've all found this true to some extent. And again, maybe it's good for therapy, maybe it's bad for therapy, but it's definitely draining for the providers, and we have to be aware of that. And then this, again, the loss of the familiar. This is actually a quote from a provider survey that we did, and I will show you some of those results. But it just struck a nerve with me. This person said, the carefully curated holding space of my office is gone. You pick out your chairs and you put them just so, and you have your art and you have a process, and all of that's gone. But I think at this time, a year in, we have sort of established new holding spaces, so to speak, for telehealth. And to people coming up with, all different kinds of psychotherapy issues, I always say everything is fodder for the therapy mill. So things come up about telehealth and you bring them into that discussion, you bring them into the process of therapy. Older adults, I have to talk about this because I am a geriatric psychiatrist by trade. And there were so many assumptions when we started. People saying that older adult will find technology hard to navigate. That has not been our experience. We have used telehealth in our geriatric clinics, and we have actually found fairly similar telehealth usage across these clinics. Assumption that older adults don't do well with change, that they're actually going to find it harder to do something new. What we found, in fact, was that their health concerns trumped the concerns about change. So they were more interested in being safe and being able to see their doctors in a safe manner, before they got vaccinated. And this idea that they would want to stick with the old-fashioned way and not have to deal with something new just didn't turn out to be true in our experience. There are some tips, though, that I think can make it more useful and more successful when you're considering telepsychiatry with older adults. So my older adult patients do like to prepare. So typically we send them the links a day ahead instead of that morning, so that they have gone through that email, they know where the link is. They are more likely to follow directions. So often sending them written directions or a written guide is more useful than telling them what to do. Utilizing support people, utilizing family, children, spouses, caregivers, that has been a big tool that we have used. Validate and reinforce success. So a common experience for me, I also run a group, now it's a virtual psychotherapy group for older adults. And so my older adults will always log on time. And then inevitably, one or two of them will say, oh, this is so hard. I don't know what I'm doing. And I'm like, and here you are on time. So because they are worried about how they're going to do, and because they're so particular, they always show up. And so you really have to validate that and help them build that confidence. Now, there are issues such as hearing issues and arthritis and speech problems that you do have to consider. And those are actually the people for whom this may not work well. But our experience on the whole has actually been fairly positive, especially with people with severe cognitive impairment, where bringing them into the office can be very disorienting for them. So the fact that we can do a visit at home and the caregiver logs in and they're right there in the chair where they sit every day, has made it a lot easier. And so in our geriatrics clinic, a lot of families seem to prefer doing telehealth for that reason. Can't not talk about impact on medical education. So again, with the pandemic, we all moved to virtual rounds and virtual supervision. And we did this in all different ways. We did this where the patient and the trainee and the supervisor were all virtual. We did this where the patient was with the trainee and I was virtual. We did this where the patient was virtual, but I was with the trainee in the office. We had one in the geriatrics clinic where I was at home, the fellow was at home, the resident was at home, the patient was at home, and then the patient's two children, one on the East Coast and one on the West Coast, were also at home. And then all 6 of us were on that Zoom call, and it was incredible. We've done lectures, we've done case conferences, we've done journal clubs, we're doing grand rounds. You know, it obviously keeps things safe for everybody. And even when safety is no longer a concern, there are things you can do using technology like group chat settings and breakout groups and using Blackboard and using polls and using virtual scenarios that actually can make virtual education a lot more interesting. So going forward, I fully expect a lot of these virtual tools to remain integrated even when we go back to in-person medical education. So, lessons learned. I'm going to show you some data that we collected. So we were doing all this, but the question was, well, what's working? What's not working? What's the user experience? So we started by collecting a clinician survey. So we did this last year, and we got about 50 responses. We said, well, have you used telepsychiatry to see patients in the past 6 months? Most people said yes. People who said no were people who were not seeing patients at the time. We asked our clinicians, how do you prefer seeing patients? And this was interesting. You know, some said virtually, some said in person, but the majority said either way, depending upon the situation. So already 6 months into the pandemic, our clinicians were learning this flexibility, this idea of we'll do whatever needs to be done in order to provide the best, most convenient care. And I think this has been a key home change for from this pandemic. $1 million question, do you think virtual visits can be as effective as in-person visits? And as you can see, the vast majority said yes. I think some of the other responses were, well, they're great for follow-up patients, but I don't like seeing a new patient like this. Some said it really depends upon the visit. Some said, yes, they're effective, but I still miss the connection with my patient. And this is data that's, again, not just us. You know, these are things that have been studied. So in 2006, there was a randomized controlled trial that said, you know, telepsych treatment through video conference was just as effective. There was a study done by Greenwald et al. In older adults that also showed that older adults accepted telehealth and that it was safe and satisfactory. And then there was this review by Hilty in 2004. And again, I'm so taken by this conclusion that I always like to read it out. But they said telepsychiatry is feasible, increases access to care, enables specialty consultation, yields positive outcomes, allows reliable evaluation, has few negative aspects in terms of communication, generally satisfies patients and providers, facilitates education, and empowers the parties using it. And I really believe that's the case. So then we asked our clinicians, what do you like most about telehealth visits? And a lot of them said how easy it is, both for patients and for them. The fact that they eliminate safety concerns, they eliminate a lot of downtime that they have running from one clinic to another, you know, a lot of the logistical problems. Some of them actually said that they find them, because they're really able to make contact with the patient, they actually find them to be more effective and more psychotherapeutically significant. What has been your biggest challenge with telehealth? And as you can see, the biggest challenges were internet connectivity, both at the clinician's end or at the patient end, and platform issues. And this is, again, something that, can be generalized. So this was a bigger survey that some folks from UConn did, and they kindly allowed me to share this in my presentation, where they surveyed 416 providers, so a bigger group, including, physicians, NPs, PAs, pharmacists, dentists, psychologists, LCSWs, other licensed providers, currently practicing in Connecticut. This was across all settings, so inpatient, outpatient, IOP, using televisits. And what they found was something very similar. So in terms of the biggest challenges, technology challenges, so stable Wi-Fi and internet connection, and then communication, establishing rapport, using services like language interpretation and nonverbal cues. This second piece is one that I think we can address to a bigger extent than we can address the first one. Likewise, the issues with reimbursement, I think, we are addressing and can continue to address and advocate for. So, next question. What's the patient experience? What do patients think about telehealth? Last year, I had found this survey of about 1,000 patients, out of which 75% expressed satisfaction, even though for 75% of them, it was their first telehealth experience. Only about 20% used them for mental health visits, though. 50% said they would be willing to switch providers if it meant they would be able to continue accessing telehealth. And 21% said they would access telehealth even if their insurance did not cover it. And 28% said they would whenever possible. So this was pretty impressive, but, this was somebody else's data, so we weren't satisfied with it. So we created our own survey, which we have been conducting since February. And this is new data, so I apologize. The numbers are not, put these on I put these together in a rush. But we have 363 responses so far, and this is an age distribution. So as you can see, about 24% of these are actually over the age of 65, but the vast majority between the ages of 31 and 65. But we do have responses from some child families as well. And I'm only sharing some of the responses with you, but one of the questions we asked was, telemedicine appointment was more convenient for me to access care. And as you can see, the vast majority of patients either strongly agreed or agreed with that. Our next question was, the telemedicine appointment was as good as an in-person visit. And again, as you can see, the vast majority of patients either strongly agreed or agreed with this statement. And then the last one, the million-dollar question. I was satisfied with my telemedicine visit and would like to continue using this in the future. And again, as you can see, the vast majority of our patients, over 300, strongly agreed or agreed with this statement. So we have the data to show acceptance on the part of both clinicians as well as patients. And in terms of efficacy, so these are our no-show rates. I'm only showing you a little snapshot across two of our biggest clinics. And so what I did is I picked the no-show rates from June of 2020, comparing with no-show rates of June of 2019. And as you can see, in both of our clinics, at Talcott, the no-show rates dropped from a little less than 20% to less than 10%. And at our other clinic, the Mood Clinic, which I run, the rates dropped from over 10% to less than 10%. So when you make it easier for patients to access their providers, they do. And so we have removed a lot of the barriers to access by use of telehealth. All right, so that's the good stuff. Now for challenges. So when I think of challenges to telehealth, I think of two perspectives. I think of systemic challenges and personal challenges. So when it comes to personal challenges, it can be things like internet connectivity, which depends upon where you're located. device availability. When we talk about this digital device, so people who are poor, who do not have the resources to have a smartphone or to have a high-speed broadband internet connection, those are the people who are still being excluded from this. And I think that's our next big challenge. How comfortable they are with technology, which might depend upon their education levels or their age. And are there any special circumstances? Do they need interpreters? Do they have, hearing issues and things like that? So for patients who are hard of hearing, for patients who don't have access to smart devices or technology, patients who have moderate to severe cognitive impairment and do not have a workaround, do not have a caregiver available to them, patients who have always struggled with technology for other reasons, patients who are medically brittle, patients who maybe you want to see because you do want to examine them. And always there are patients who just plain refuse. So these are all patients who, you can and should bring into for in-person visits, and that's totally fine. In terms of safety risks, some of the things that we recommended to our clinicians was anytime you do a virtual visit, always confirm that your patient's safe, that they are private. Make sure you know the address where they are at right now and the contact information. You conduct a safety assessment just as you would do in person. And it's important for you to have an independent phone line so that if there is an issue, you can still keep them on video with you while you use the other line to call for help. When it comes to substance abuse, as I said, Ryan Haidt is now back in action. And what the Act says is that a practitioner cannot issue a valid prescription for a controlled substance by means of the internet without having conducted at least one in-person medical evaluation in the previous 24 months. So these are the things that we are now building into our structured program, telehealth program going forward. In terms of systemic challenges, documentation and coding requirements differ by state. And so the only way to keep up with this is to keep up with it, to keep following them and tracking them, which is work. Billing and reimbursement, we have parity now in Connecticut for the next 2 years, but not all private payers are required to cover telehealth. So this is still very much a moving target. Platform transitions. So we transitioned from CME to Zoom. We might now transition from Zoom to Epic, and there is always a learning curve and some, challenges that come up every time there is a transition. Every time you scale up or scale down, there are issues. There are always security concerns. So overall, I would say we've done really well with them. And then licensure and travel, right? So what if I travel out of Connecticut? What if my patient travels out of Connecticut? One time I had a patient who had traveled to Peru and decided to do a televisit from Peru. So these are all the things that you have to keep up with. Lastly, what's going to happen now? What's the future going to look like? And this is another quote, another comment from the provider survey that we did. And I liked it so much that I put it on a slide. Are we doing this forever here on out? To which my answer is that probably yes. The genie is out of the bottle, as the ex-administrator for CMS said. However, it's not going to be exactly the same as it has been in the past year. I think where we will end up is actually some sort of a hybrid model. So a combination of in-person and telepsych care, which I think gives flexibility, again, both to patients and providers. Expansion of telehealth policies and reimbursements. We're already starting to see this. This slide predates the Act in May. Combining various data streams to build a more comprehensive patient picture and an individualized treatment plan. I think this is going to become more and more important. I have a patient who's in her late 70s who I've seen for years, who recently sent me a whole report from her Fitbit, including the hours of restful sleep, the steps, and, I've been treating her for insomnia for a very long time. So having real life actual updated data and being able to incorporate that in my treatment planning is going to be very, very useful. I think we're going to continue using virtual tools for didactics, and we're also doing this using remote visits to augment training. So right now I have a telepsychiatry elective and I have medical students coming in, and because they can do all this remotely, I can have them attend hundreds, and not hundreds, but as many things as they want to do, because time and distance is no longer a barrier. Here's some wonderful resources. The American Telemedicine Association have been around for a long time. They have some great resources. Center for Connected Health Policy has updated policies for every state. It's a wonderful, wonderful resource. Both the APAs have their own toolkits, and we have regional resources. So there is a Northeast Telehealth Resource Center, which talks about issues specific to Northeast. So I really want to thank you all for this opportunity. I think I have the slide here for those of you who need the CME code. And I will stop. No, this would disconnect from the meeting. I don't think I want to do that. Okay, here we go. All right. So if you have any questions.
Can you hear me, Neha?
Yes, I can. Can you hear me?
I can hear you. Yeah. So, all right. That was amazing. And I mean, so I said it was going to be timely, but in addition to that, so clear, so thorough, to see the data, to see the graphs, so you were primed to know this stuff inside out because you'd been interested in it before. So I really feel thankful. I loved the hacks. I loved the zombie apocalypse thing. By the way, that was my wife was saying that the only thing you ever have to worry about to the kids is the zombie apocalypse, and then it happened.
Then it happened.
I also really loved the detail, that timeline of all right. So now here's my job starts when I have to start juggling people's questions. So let me start, and I'll try to paraphrase them. One is about, you mentioned groups a little bit, but can you say a little bit more about your experience with groups on telepsych and also inpatient on telepsych?
Yes, so we have been doing groups using telepsych now for a while. I run a geriatric mood and anxiety psychotherapy group, which is once a week, an hour. And so we've been running that using Zoom from the very beginning. And, most of these patients are in their 70s, some in their 80s. We have really had zero issues. So that's actually been, pretty much just like you would conduct any other group. What's been more interesting is though our intensive outpatient program, because they don't do just one group. So they have, a group visit, and then you have an individual visit, and then you have a mid-management visit. So it's a longer process, and there's many groups that patients are attending that day. So they, I believe, are still using WebEx. And using WebEx, they have been able to schedule various meetings for patients so that if 6 patients log in for the day, they all have slightly different meeting schedules, and they have been able to conduct intensive outpatient program using telehealth with a really good success.
Excellent. And how about inpatient?
So I don't believe that inpatient we are using any telehealth right now. We did play with the idea of using remote patient visits in the very beginning when we were worried about our providers' health and, if somebody was quarantined or if the whole unit was quarantined, then the providers could do some virtual visits. And we did do some, but overall the inpatient environment did not lend itself to telepsychiatry, mostly because from our clinicians, the feedback that I got was, look, I can go and see my patients remotely, but then the nurses are still on the unit and the staff is still on the unit, and it is not necessarily good for unit morale for some people to be there and some to not. So they made the decision to work together as a team, which I think was fair.
Excellent. A lot of people saying you really validated our experience, particularly with respect to the challenges we're facing keeping track of insurance, the technology, the state issues, technological limitations. Here's another question regarding billing. Any difference in terms of ability to bill for specific codes compared to in-person visits?
So as of now, no. So anything that you do in person with a patient in Connecticut, you can continue to do that virtually. And if the specific payer plan reimburses for telehealth, then they are required to reimburse for that service at the same rate. So we have done everything from case management to psychotherapy visits to med managements to intakes to neuropsychology visits through tele, and we haven't faced any reimbursement issues in particular. But remember, just keeping in mind that this is a moving target, that this is something that is likely to change in another few months, and that we have to keep tracking it.
Excellent, thank you. And Rob, if you're listening, it looks like Hank was beginning to type in a question in the chat, and he might, oh, there it is. So I'm gonna read it. And Hank says looks like it's the future, but the loss of three dimensionality is important in how we perceive our patients, and we might even say four-dimensionality given all the senses, right, or five-dimensionality. We lose awareness of body posture, other modalities we may not be aware of, even sense, and the unique connection which accompanies that. What is your with the caveat that we're still learning. I mean, we're just now getting data because there's so many visits now, right? But you're ahead of the game. So what is your sense of what's being lost, and how do we even know what's being lost relative to not being in the room with people?
I think that's a very good point. And I think there's no denying that these are two very different modalities of examining your patient. So having somebody in the room right next to me and, being able to see both the verbal and the nonverbal cues, and, maybe they're tapping their feet and, how they're dressed and what they're smelling of, like he referred, those are all important data points, right, that I use in my assessment of a patient. The important thing to remember, one, is that telemedicine is just a tool. So this is not the end game. This is just something that allows you to play your game, that allows you to do what you're going to do. So while I lose a lot of the awareness of maybe body posture, maybe their scent, maybe how they're dressed, I might gain some insights into what's happening in their environment. Why do they have an old sheet hanging behind them to hide whatever is happening behind that? So while I lose some sources of data, I might gain some sources of data. But the bottom line is that this is still a tool. So what I foresee very much is that we're not replacing in-person visits with televisits. We are incorporating televisits into in-person visits. And so in an ideal world, you will have everything. You will have opportunities to see your patient in person and all the information that way. And then at some other time, you may see them virtually and gather even more information that way. So this adds to that overall picture that you build, that overall composite that you build with the information that you get.
Yeah, it's a great point. So, we wouldn't think twice especially if it's a combination. We see our patient, we've been seeing them for a while. We have a telephone call every once in a while. We don't think about that twice, and so it's another modality of connection. Although if it becomes the primary modality, and Hank has a follow-up around the effect on the clinician, the exhaustion working into dimension. We've heard about Zoom fatigue. I mean, personally, I am just so tired of Zoom, and part of that's tired of not being in the room with colleagues. You know what I mean? But do you
Yes.
have not necessarily data back, to back up, but just a general walking around sense. Are there some people that are just more immune to it, as clinicians, and maybe better at it? I mean, you think you're really good at it. I mean, the way to manage the video and being on camera, like you said, and what's your experience with that?
Yes, so I actually think, again, that is a very valid point. There is, the primary feedback that we got in the beginning was all about clinician exhaustion and just how tiring people felt that this was. And I have definitely experienced this myself. I really don't think anybody is necessarily immune to it. I actually used to have a slide, and I think I took it out, but there was a sort of a tip slide for clinicians to say, making sure that you take Zoom breaks. And one of the nice ways that we've been able to do that now with the reopening and the vaccinations is having televisits mixed with in-person visits. So we will do a few televisits and then we will have an in-person visit. Even when I'm doing all televisits, you have to figure out what sustains you, what provides you some relaxation. So for me, it has always been greenery. And so I've always have my computer next to a window. But I tell people, take, even if it's a 30-second break, to get up and away from that computer and walk. If you're working from home, go out and say hello to your dog. If you're working in an office, step out and say hi to whoever's next door. This is new, and this is very much a different working environment, and we do not want this to affect our own mental health. So there is definitely things we can put in place to battle that. But very much, I think we're going to see this evolve even more.
Very interesting. So for the clinician, mixing it up, say a patient, some patients want to be virtual only, but for the clinician during the day, mixing up virtual and in-person.
Yes, I do that, because initially we had actually discussed doing only telehealth clinics and only in-person clinics. And then we realized that would not be such a good idea, because as clinicians, we need that variety. We need that three-dimensional exposure as well.
Okay, excellent. Another one is definitely admiring the data that you're bringing before us around patient experience, clinician experience. It may be early, but anything in terms of actual outcomes, quality metrics, drop in PHQ-9s or other, to compare and contrast the quality.
Yes.
Quality.
That, unfortunately, is something we don't have. We don't, what we do have in terms of quality data is no-show rates and patient visits. But in terms of, hospitalizations and ED visits and PHQ-9 scores or GD8 scores, we don't have data. Primarily, I think, because this wasn't something we were collecting before, so it would be hard to do a compare and contrast. But that is something we're interested in. And in fact, because I think we could easily look at something like ED visits or, rehospitalization rates or something like that. I do think it would be very, very useful. And even though we're not doing it, I know people who are, so I would expect to see some of that get published this year.
And I would add, in terms of anecdotal, and this is, we would hear, and it may not be a big N, but, the people that end up filling out those surveys are the people that are in treatment. And so who may have fallen between the cracks, particularly in the heat of the pandemic, the worst of it, when it was all virtual, and we definitely, and I'm sure you had patients who, and I can remember some that, particularly with bipolar disorder, agitated, who just could not do virtual and ended up, they couldn't do IOP, and they ended up getting hospitalized because they felt they couldn't tolerate the medium. Did you have any thoughts about that?
So
who may have fallen between the cracks that don't show up in the surveys?
I think so. I think there is definitely a significant subset for multiple reasons. It could be the severity of their mental illness. It could also be, again, due to poverty or lack of resources, who are then not able to utilize the medium and not access care. And so those patients, suffered during the pandemic. But at the same time, because again, our data is biased towards people who are accessing our system. So the information, and we have individual comments as well. I put them in today, but most of the feedback we've gotten is people saying, how this saved their life during the pandemic because they could still see their doctor and they were able to keep up with their visits and they're so grateful. But I think the truth is definitely somewhere in between, which is why I think this post-pandemic future, this idea that we can do everything and just use everything at our disposal to increase access to care is what's really going to be useful.
Excellent. Again, lots of positive feedback. This is fantastic. A question here. This is a very in the weeds question. You mentioned something about a silent keyboard. What is that?
Yes, so you can actually get keyboards that are silent so that, when you're typing, people don't hear the noise of the typing. So those are, I think, fairly easily available. I actually used them initially, then I stopped using them because I realized I'm a silent typer anyway. But for people who, especially if you get feedback from your patients that they can hear you typing, investing in one of those might be very useful.
Interesting. They're called silent keyboards.
I think so. I'm trying to remember. There may be another term as well. But I can send it to you. I can find it and send it to you.
Great. And this might this might be one of the last ones. Do you have any opinion about asynchronous? Any experience with it? And I would add to that. I don't know. Is it Talkspace? Those. I've certainly encountered some people who actually health professionals that really like asynchronous communications by text to be able to, and also being able to schedule appointments on the fly because it's so much more convenient. Do you have any thoughts about asynchronous telemedicine and things like online programs like Talkspace?
Yes. So my biggest experience is actually with asynchronous communication through the EMR. So I predominantly rely on the Epic Secure messaging to communicate with my patients. I actually do not use the phone at all. So all of my patients send me messages through Epic. And I do, again, feel that is extremely useful because, again, when you're checking your voicemail, you have to rely on a specific time of the day, right? You have to find 20 minutes during your day to check into your phone and respond to those voicemails, as opposed to when I have patient messages in the same EMR that I'm using. It's very easy for me to go over my messages and respond to those messages and address medication questions, side effects questions, symptom questions. So I find that very useful. We have not done e-consults in the Department of Psychiatry, but I do know that within UConn, there were some other specialties that were also providing clinician-to-clinician consults using recorded data. So they would, the one clinician would have patient data and send it forward and get consults from an infectious disease doctor or an endocrinologist and so on. So I find it very, very valuable. Again, it can't replace in-person care, but it is a very valuable tool and I think very convenient both for the patient and for the clinician.
And online therapy, like Talkspace?
So there, I would withhold judgment on online therapy. I think the jury is out there. I think we're going to see data. They're certainly very popular. Yeah. But I don't know if there is convincing data out there yet in terms of whether it works and how well it works.
Got it. Let me actually try to get one more in. Do you have anything that you would say about the difference between telephonic and televideo in terms of any of these outcomes and, given connectivity issues, given socioeconomic issues? What's your opinion on that?
going back to, what one of the comments was saying, I always see these as data points. So when you have an audio call, you are getting, audio data. When you have an audiovisual call, you are getting audiovisual data. When you have an in-person visit, you're probably getting audiovisual and then some nonverbal data. So if we put them on a spectrum like that, a video visit is obviously better than an audio visit. But if we think of it from an equity standpoint, so now I have a patient who can't come in because they don't have money for the bus, and they don't have a smartphone, so they can't do a video visit. And the only thing I can do with them is a phone call. That phone call is better than no phone call. So yep. I always think of these things as being on a spectrum. And again, if our goal is to keep our patients well, yep. and to keep them out of the hospital, then we utilize any modality that is appropriate for that patient. But that's always going to be specific to the patient and to the situation.
That's really super helpful and really just fantastic answers, like right to the point. I think I saw something on Twitter yesterday, and I'm trying to remember what country, but I think they said like 90%, whatever country it was, maybe it's Australia or something, that 90% of their virtual visits during the pandemic were telephonic. So it's going to be interesting to see, like, as the data really starts to pour in, the millions of visits, and it's really going to inform. So I really want to thank you, Neha, for joining. I mean, just how lucky we are that you're right next door, that you were, already an expert on this and really interested in it, and to have you ahead of us, the rest of us, to be able to, kind of bring us up to speed. And of course, you're still investigating this, so we really look forward to, having you back maybe and hearing from you and reading the publications that will come out of this. And but I just and lots of positive feedback I'm getting about your talk. So thank you very much for spending the time with us.
Thank you so much. My pleasure being here.
Take care.
Bye.